welcome to the Preemie Chats. Preemie Chats is a program that is for healthcare professionals and parents to talk about what matters to you, to explore new ideas, and to learn together. I'm Fabiana Bacchini. I'm a Preemie parent and Executive Director of the Canadian Premature Babies Foundation, and I'm happy to be your host today. Preemie Chat was created by the Canadian Premature Babies Foundation, also known as CPBF. The foundation is a parent-led organization that helps families in and after the NICU through education, support, and advocacy. If you have a heart for preemies, whether you are a family or a healthcare professional, please check our website, canadianpreemies.org. There you'll find resources, the latest projects, and most importantly, a community of people who want to see our little babies thrive. If you're watching live, please bring your voices to this table. Leave comments and questions in the chat, and we'll try to address them during our program. It is through rich conversations like this that we can advance practice and learn together. So please participate and let us know where you're watching from. And today we're going to talk about empowering parents and engaging children. What happens after the NICU? In this chat, Dr. Peter Gill will introduce the Canadian Paediatric Inpatient Research Network, which works with children and families to generate evidence that improves care and outcomes for hospitalized children in general pediatric settings. He'll talk about a recent project that asked parents and families to prioritize the most important areas to conduct research and about current projects which focus on incorporating shared decision-making in hospital. Joining him will be Francine Buchanan, who will share her personal journey from the entering the NICU as a terrified parent to a 26-week baby to studying shared decision-making and now empowering families to partner in research. And I have Francine and Dr. Peter Gill joining us live from Toronto today. Dr. Peter Gill is a general pediatrician and an associate scientist at SickKids Research Institute, an assistant professor in the Department of Pediatrics at the University of Toronto, and a senior associate at the Center for Evidence-Based Medicine at the University of Oxford. His patient-oriented research program focuses on improving the care and outcomes for hospitalized children on the General Pediatric Inpatient Unit. Dr. Gill is also the co-founder and vice chair of the Canadian Paediatric Inpatient Research Network, a network of all children's hospitals and several large community hospitals. Dr. Peter Gill, welcome. Thank you for joining us here today.
Thanks for the kind introduction. It's great to be here.
And Francine is the program manager for research, patient, and family engagement in research at SickKids at the Ontario Child Health Support Unit. I would say Dr. Francine Buchanan, because you earned this degree, and we are so proud of you, Francine. With all your journey, you still went to do your PhD. So in this role, Francine supports the hospital's child and family-centered care philosophy by ensuring patients and families can partner with researchers to co-create child health research that reflects the lived experience of patients and their families. I'm so honored to have both of you here today. This will be a great chat because I admire both of you so much when it comes to patient engagement. So I will let you take the floor, and to all of you watching us live, please do send your comments or questions. Share with us, are you involved in research? And then we're going to have a chat at the end of your presentation.
Great, thank you very much. It's really so nice to be here. And that was a very kind introduction, Fabiana. As you mentioned, we're going to be talking about empowering parents and engaging children, what happens after the NICU. So just a couple extra background points. So as Fabiana mentioned, I'm a general pediatrician, so I spend about 3 months of the year taking care of children that are in hospital on the general pediatric ward, and then the rest of my time I lead a research program, which we'll talk more about today. I don't know if Francine, you want to say anything else about yourself before we get started? No, well, let's get going. So first of all, we just want to take a moment to acknowledge the ground beneath our feet is historically the home of the Indigenous peoples from across Turtle Island. For thousands of years, the land on which our presenters we reside has been the traditional land of the Anishinaabe Algonquin Nation, the Huron-Wendat, and the Petun First Nation, the Seneca, and most recently the Mississaugas of the Credit River. We are grateful to have the opportunity to be present in this territory and for the opportunity to share this land. So in terms of what we wanted to talk about today, and it's meant to be informal, engaging, and interactive, is we want to first describe and talk more about the Pediatric Inpatient Research Network, to describe the most important priorities for research for hospitalized children, and an example of some of the projects that we focused on. And that we really, and most importantly, want to empower parents to use their experiences to improve healthcare in the NICU and beyond. So I want to start with some photos that will likely be very familiar to many of you, which is in the NICU, the intensive care unit. These are actually photos that I found from the Trillium Health Partners NICU, which is a community NICU. And many of individuals here will have spent weeks, maybe even months in a place like this. So it's a familiar location, may trigger some strong emotions about this experience. Next, I wanted to show some photos of what happens, which may or may not happen after, is at the General Pediatric Inpatient Unit, the General Pediatric Ward. And these are some photos at the Hospital for Sick Children in Toronto, which is where I practice. And there is some similarities, some differences, but the General Pediatric Ward it's a distinct area of care that, in some sense, like the NICU, it's a whole special area, and it's different from other areas of the hospital. And in this setting, we take care of children of all ages, including newborn babies, including babies that are transferred from the NICU onto the ward if they've kind of graduated, up to teenagers and adolescents. And the conditions managed in this area are quite broad, ranging from acute illnesses like the stomach flu or bronchiolitis to conditions like epilepsy. And also we take care of children with medical complexity that may be hospitalized for various reasons. This is actually also the setting where I first met Fabiana several years ago, when I just started and became staff at Sick Kids. Her son Gabriel was admitted to hospital on the General Pediatric Ward, and a ward similar to this, and I happened to be the staff physician, and I distinctly remember her real clear ability to communicate, her strong advocacy skills for her son, and it was a very positive interaction of seeing a loving parent. And it was somewhat surprising that I saw her a year or two later, when we both happened to be members of an institute advisory board at the Institutes for Health Research. And we had this sort of moment where we locked eyes and recognized each other from our experiences before. And it was this past fall when we were at a meeting together, when I had a somewhat obvious realization that for many of parents of graduates of a child in the NICU, that many times their experiences in hospital after, if they do happen, will be more commonly on the General Pediatric Ward. And there really is a nice opportunity to work together into how to collaborate in terms of thinking of the NICU and beyond. So a bit more about the General Pediatric Ward Inpatient Unit. So it's one of the largest units in many hospitals. At Sick Kids anywhere, we have from 50 to 90 patients admitted at one time. And across Canada, about 1/5 of all hospital admissions are on the General Pediatric Ward. And it's important to note, very similar to NICU care, that a large number of children are cared for outside children's hospitals and community hospitals. However, despite being such a large area of care, it's an area that lacks a lot of high quality research. There's very few randomized controlled trials, and there's many other low quality studies, and there's lots of barriers to conducting research in this area. So to address these knowledge gaps, several colleagues and I, back in 2019, launched the Canadian Pediatric Inpatient Research Network, or PIRN, with the goals of how can we generate scientific knowledge on the General Pediatric Ward, just really to improve outcomes for hospitalized children. This photo includes from our inaugural meeting in 2019, where we really embedded patients and family partners from the outset. And actually, Francine was fortunate to speak at our initial meeting. And we had speakers from several other networks, including Dr. Prakash Shah, who is one of the leads of the Canadian Neonatal Network, around how we can learn from other networks to how to generate evidence to improve care. And we had representation from children's hospitals from across Canada, from St. John's to Vancouver, and several large community hospitals. And it was at this inaugural meeting that we set out to define our mission, vision, and our values in terms of what we wanted to focus on. And our core mission is that we work with children and families to generate evidence that improves the care and outcomes for children and hospitalized, for hospitalized children on general pediatric wards. And we build research capacity through mentorship and collaboration. And our vision is that we want to achieve the best quality of care for hospitalized children in general pediatric settings. And our core values are excellence, child and family-centered care, inclusivity, and collaboration. And it was with these core values that we set forward to try and tackle improving the evidence in this area. But one of the first questions that we encountered is, now we've developed a research network, we have a mission, vision, and aims. Well, what do we focus on? What are our strategic priorities in terms of, some networks have either just focused on what individuals have strengths in or experience in, but we wanted to outline some set of priorities that really provide us a set of specific concrete tasks for us to focus on, and that would also be transparent and open so individuals would know how we identified what we wanted to focus on. And we looked at different ways that we could actually identify priorities for us as a network to focus on. And we had come up with an important methodology, and I had actually learned about this when I did my PhD in the UK. There was a not-for-profit organization called the James Lind Alliance, was started a couple decades ago, which is a not-for-profit, which at its core is about bringing together patients, caregivers, parents, and clinicians in priority-setting partnerships with the goal of identifying and prioritizing areas where there's a lack of evidence or where there's research uncertainties based on areas that people feel are the most important. And we thought this would be a really appropriate way for us as a network to engage with our community, with our parents, caregivers, with youth, and clinicians to understand what's the most important, what are important questions to them for us to focus on. And we were somewhat fortunate that at that same time, there happened to be a grant call from a funding organization for projects which specifically bring together researchers, knowledge users, clinicians, and parents to help to work together collaboratively for a project. And so, in doing so, we worked hard to develop, a strong application with many partners, including hospitals from across Canada, academic and community hospitals, strong patient engagement from various children's and youth councils across Canada. And the large number of partners is a testament to the importance of our project. And this is actually where I had the first opportunity to meet Francine Buchanan, which was as part of my journey of how do I, as a pediatrician and a researcher that wants to work with patients, how do I do that? What's the process? And sort of I stumbled upon Francine to help guide me along my journey of how we can learn from each other. And really that's been, I think, the first of now many projects working together around really I think, co-researching together and learning from each other and really focusing on delivering a really meaningful and high quality product. So we were successfully awarded the grant, and interestingly, we actually were ranked #1 in the whole competition of over 150, which I think reflected on the strong integration of parents as partners through our project. And the high-level process is that essentially we established a steering group which oversees a party-setting partnership. Then we sent out a survey to gather unanswered questions from parents, caregivers, youth, and clinicians on what's the most important questions for them. We then do an evidence search to find out which of these are actually evidence gaps, so don't actually have strong evidence supporting them. We do another party setting, and then actually, finally, we have a final top 10 workshop where we actually select the top questions. So our steering group, most importantly, was overseen by an equal number of clinicians and parents and youth. So we had our James Lind Alliance consultant, and we had 2 nursing colleagues, which nursing care, as many of you know, is such an important part of stay in hospital. And we really wanted to integrate the perspective of nurses as part of this process. We had 2 pediatricians, we had 3 parents and caregivers, and 1 youth. And this was a steering group that oversaw this entire process. So there was equal voice from both parents and from clinicians. And as you can see, this happened during the COVID pandemic. So all of our meetings were virtual, but we had a lot of fun meeting quite regularly. We initially had almost 500 responses from parents, youth, clinicians across Canada to this question of, what concerns, comments, or questions do you have about the care of children in hospital in the general pediatric ward that you would like answered by research. And this is why we tried to solicit input and feedback to come up with our priority list. And then when we sifted through all those in those responses, we framed them into questions, and we had our final workshop where we brought together 12 parents, caregivers, and youth, and 12 clinicians, nurses, occupational therapists, pediatricians, to have a 2 half-day session where they went through the top questions and worked through to come up with a top 10 list that was felt to be ranked by both. And this was a really fantastic process that really allowed both perspectives, parents and caregivers, youth, and clinicians to be in the same virtual room to understand different perspectives on what's important and why. And this was we had representation from across Canada. We had a nurse from Yukon, from all across. So it was a really great session. And well, this is a photo from that. And ultimately, we came up with our top 10 list of unanswered research questions. And there was many that we had discussed, but these were the top 10 that were ranked at that virtual workshop. And interestingly, as a researcher, I was not actually part of that process. So I had no actual vote in these top 10. And so I'll go through these and highlight them and then switch over to Francine. And many of these I think resonate with those in the audience. So the top most important question was, what are best practices and care models for inpatient care for children and youth with medical complexity, and certainly on an everyday hospital, and how best do we care for children in hospital? What are methods of communications that are most effective between parents, caregivers, and healthcare professionals? What are best practices and support strategies for Indigenous parents and families in hospital? How can we ensure that healthcare delivery in hospital meets the needs of children and youth with developmental disabilities, for example, someone with autism? And what are effective support strategies for parents and families in hospital? Because it can be quite a stressful stay, it can be prolonged, it can be very challenging. How are we helping families? What are mental health supports for families? How do we incorporate shared decision-making into routine care? How do we mitigate the impacts of prolonged stay in hospital, which can be a real challenge? How can we effectively shorten length of stay where possible? And what are the different effective ways to communicate between healthcare providers? So certainly from the perspective of a pediatrician, these really resonate and are some of the questions and issues that we grapple with every day of how best should we deliver care and how do we focus on these. And so now I'll pass over to Francine to take over to talk from the parent perspective.
Thank you so much, Peter. As I looked at these, answers as they came back, these research questions, they really did resonate with me. When I was looking at them, and I'm wondering to the NICU parents in the audience as well, if you have kind of a same reaction as you look at these and say, yeah, kind of the NICU I was in probably could benefit from answering some of these questions too. So for parents like us, if your child, even if they haven't been readmitted and you haven't had to stay in the hospital since they were discharged from the NICU, I bet these questions made you feel, some of your past experiences come back to you and really resonate with those experiences that you had. And I have a theory about why these questions resonate, why this process of looking into things is important to study. It's because this wasn't just a bunch of doctors or nurses sitting around in a room coming up with these questions. These questions were really developed with parents, caregivers, nurses, and doctors. It was a collaborative process. It included the perspective of parents. And when you include the perspectives of families, our experiences in hospital, they really do cross over units, they cross over floors, and they cross over time. What matters to us, what improves our ability to heal, the ability to fight illness, the ability to just survive some days, those things come down to the little things that aren't often studied. But what I didn't know when I first walked into the NICU, terrified, uncertain, and with little hope, is that this stuff wasn't always studied. My journey started almost 10 years ago this coming week. I walked into the NICU, probably like many of you, unsure of what was to come. Before my son was born, I had some fleeting experiences with healthcare, a few trips to the ER, maybe for a burn or a sprain. I had regular visits with my GP, but nothing like the next few years of my life would entail. I was not a nurse, I was not a doctor, and I was far from a health researcher. I was just a regular member of the rat race, getting up every day, going to work, and thinking about what I was going to make for dinner. But during the 16 months that my son spent in the NICU and then followed by the PICU at Sick Kids, the roller coaster ride was intense. We were thrown new diagnoses almost every day, sent new stuff to read, and had lots to learn. It felt like every day we were again hit with bad news, a major decision, or new information to consume, all for healthcare. Some days I felt really, really good. Those were the days I would get a smile from my son. He would meet a milestone, maybe gain a few grams, eat a little more food. But some days I felt bad. I was faced maybe with a tough decision that I didn't know if I knew enough to really answer. Sometimes I felt out of place, where people were telling me things that they thought I should know, but I didn't, and I was too afraid to ask. Some days when a doctor would say something kind of that took me by surprise, and I really had to think, did I take that wrong? They can't really have said what I think they said. I knew I wasn't a doctor, but I knew how I felt. I knew that those yucky days, those days that I went home and cried, not because of a diagnosis, because we felt alone and adrift. I knew those feelings existed. I had experienced them. What I didn't know was that others felt that way too. And we all knew, I can imagine, that we didn't want others to feel that way in the future. The problem wasn't the doctors themselves. It wasn't the nurses on a personal level. It was that these experiences, these yucky days, it's that they existed, but there really wasn't a push to understand those experiences. They weren't a priority. It felt like they were just kind of individual problems that each family addressed on their own in their own way. With minimum research resources and money, the focus is on studying how to predict sepsis, how to minimize the negative effects of oxygen. So what that left me as a parent is wondering, am I coping the way that I should be? Should I share with the doctors how we do things at home? Will anyone listen to me if I do share? And what happens if I don't do exactly what they say because it doesn't work for our family? I felt those things in isolation. But when I saw those top 10 priorities, I knew I wasn't alone. Doctors felt it, nurses felt it, and other parents felt it too. And that's why many of the top 10 priority questions address how we communicate, how we share information, and how we share decisions. But the top 10 priorities are only the start of the process. Now, the hard part comes. We have to tackle those questions, and we need to tackle them together. Now, naively for me, I went back to school after my son was born. I completely switched careers. I went from business to studying health research because I thought back then that I needed to learn about healthcare from the healthcare provider's side. I thought I needed to speak like a doctor, act like a doctor, think like a doctor, solve problems the way they do. So I did the closest thing I could. I went back to school to study health research, and I sat in the classrooms next to nurses, doctors, pharmacists. But what I learned in school is that we can't solve these problems by only looking at them from one perspective. That's the perspective that currently dominates research, and it's the health care provider's perspective. When my son was discharged from the hospital, for example, he traveled with a mini ICU. So he had a ventilator, oxygen, feeding pump. And as amazing as the doctors were in ensuring his ventilator pressures were perfect, they had never experienced trying to deal with a ventilator malfunction on a TTC bus. That came from experience, my experience, and the experience of other parents like me. But both experiences are important. Whatever ventilator pressures are, whatever medical supports are needed, they can't be done without the cooperation of parents or caregivers who administer it. Together, knowing the science of ventilators and the experience of caring for someone with one is magic. We can improve the care of ventilator patients much better knowing both perspectives. And that's how we plan on tackling the top 10 unanswered questions. And we've already started. So if we look at priority number 7, the question is, what are effective ways to incorporate shared decision-making into general pediatric inpatient unit care? Every day on the Gen Peds floor, there's numerous decisions being made. We're still trying to understand what decisions parents are being included in and what decisions are happening without them even knowing it. Those decisions parents may want to be part of. From my personal life, I can tell you how my son deals with IVs. If a nurse is deciding if he should be detached from fluids or with a saline lock, or he should continuously be running fluids to keep his veins open, I want to be involved in that decision, mostly because I know which one works better for him at different times. I've experienced both, but for another person's perspective, if they hadn't experienced different types of IV locks, they may want guidance in deciding how to make that decision, or they might not want to decide at all. So there's a lot more to understanding about what decisions we can make on the general peds floor. And what we're tackling first is one step towards that by involving caregivers. So this study is called the I Know to Grow study. And it's our first step in understanding how to guide parents, caregivers, and doctors and nurses to share decisions. We're involving parents in the process of designing an easy to remember way of sharing information. The name I Know to Grow is actually a mnemonic, it's an acronym to help you remember things you might want to share. So it's, what do you know? What have you observed? What do you want? But when we design this back in the office, it means nothing if you and the family won't use it and don't like it. Same goes with the doctors. There's no point in sharing a tool if no one's actually going to use the tool, which is why we're bringing together clinicians, nurses, patients, caregivers to take what we have thought of and designed and make it much better. Good collaboration really does make things better. The next study we're looking at is what's the best way to administer fluids to a patient admitted for bronchiolitis? If you were a parent in the NICU, you probably saw both these forms of fluid administration. Some of your children might have received fluids through an NG. Others may have received fluids through an IV. Your experiences with one versus the other, your experience of both, are real valuable insights and can help shape how this study is done. In this case, the top 10 priorities reminded us that sharing decisions are important for families. So rather than doing research to kind of convince families that one is better than the other, or to research which one is better, if they both, the data shows us, have equal effect, then why not look into if parents are being given the option? And if they are they comfortable with making that decision? I'm going to pass it back to Peter now to talk more about this study and a couple others that we're doing. But I really want you to get a sense that the work we're moving forward with really involves patients and families, because that's how we can frame the right questions to ask when we're tackling topics like this. All yours, Peter.
Great, thanks, Francine. And as Francine mentioned, we're really trying to understand and look at questions from both perspectives. And so bronchiolitis is one of them. It's the most common reason children under the age of 2 admitted to hospital. And one of the main reasons the children have to be admitted is because they're not feeding well and they get dehydrated and they need supplemental fluids. And as a trainee during my residency training at the hospital, we would often have fellows or staff from all over the world, and it was really, I observed differences in terms of someone using intravenous to give fluid, someone using nasogastric tube, because you can give breast milk or formula, and it really was unclear why one versus the other. And so we had spent some time, looking at the evidence, seeing, is there actually one that's superior or better than the other? And really, both of them are equally effective, but have different trade-offs. For example, IVs can work really well if they work, but if they fall out, have to be reinserted, and there's multiple pokes, multiple attempts, that can be really traumatic. If for a certain family, breast milk and breastfeeding is really important, a nasogastric tube can allow the provision of nutrition for families, which from the NICU perspective is really critical. But then, someone may have had a parent or grandparent that the nasogastric tube reminds them of, cancer therapy or bowel obstruction. That could really bring out really negative perspectives. And so part of it was, wanting to understand, well, are actual, parents involved in these decisions when the evidence for them is sort of similar. And this is a quote from one of our parent partners who works with us, Kim. Her little girl, her daughter was admitted several years ago with bronchiolitis, and she was actually a participant in one of the studies. And she had said, if I had known that nasogastric fluids were an option, I would have asked for it. It was awful seeing Marceline so hungry, and I wish I was involved in the decision. And that's as an example of how can we incorporate and engage families in our decisions and sort of understand what's important for them. And so, as Francine mentioned, one of our studies is integrating the perspective of what's a common condition that we see that's a major around the healthcare system, bronchiolitis, and also shared decision making, which is a key important question driven by parents. And we want to understand and generate knowledge on shared decision making with parents in choosing either between intravenous or nasogastric fluids for hospitalized children with bronchiolitis, and really to understand more around the benefits and harms of these treatments. And one example of an evidence gap that we're trying to fill is a lot of the studies on this topic have excluded preterm infants or infants that are under the age of 1 month because they have different risk profiles. But those are groups that often have some of the highest risks of getting admitted with bronchiolitis. So it's really important that when we conduct studies, we try and be as broad as we can to include those patients that may be most likely impacted. And for this study, one of the main outcome and is actually understanding the extent of involvement of parents in shared decision making. And there's a newer shared decision making tool that we're evaluating in this study, and it's truly a matter of have practitioners help families understand the issue, listen to what matters to them, and include what matters to them in actually choosing what to do next. And so that's a real focus. And so we're just starting the study, launching this at sick kids in a community hospital, Lake Ridge, fairly soon. And I'm seeking to get funding to do this across Canada, multiple hospitals. And the idea is this will help us, generate information. How do we better incorporate shared decision-making into routine practice? So that was really a high-level talk. We wanted to provide a good perspective on what we're doing in PIRN, the research network, and how we're partnering with parents and families to improve evidence and improve outcomes for children in hospital. And we'd really be happy to answer any questions, and want to thank everyone for the time. And we also wanted just to put our contact information up in terms of feeling free to also get in touch with either Francine or I to get more involved, ask questions, and see more about PIRN on our website there. But we're happy to have answer any questions or talk more now with the rest of the time available. So thank you.
Wow, thank you so much, Francine and Peter, for sharing your experience, and Francine for sharing your story. A lot of what you said, I could totally relate to you, especially the NICU days and going to pediatric floors. Wow, that is outstanding work. So let's unpack a little bit, because there's a lot of work done to get to that point where families and caregivers are truly partners in this work. So, Francine, for you, how was the process for you to get involved in research? You came as a non-medical mom to become an expert. So how was that process for you?
So I'll tell you, I started the process prior to returning to school. So I started the process actually while I was sitting next to my son's bedside in the PICU, actually. And I'll tell you, one of the first instances I had was I was asked to participate in a research study, and they asked me to fill out a survey. And I read the survey, and I got back with the researcher afterwards, and they said, this was really hard for me to fill out. Like, the one thing that sticks in my brain is, what medications is your child on? And my child was on a lot of medications, but they gave you a little section to fill out for your medications. So it was really, really a simple, low barrier to entry way of starting. It was just giving some feedback on the forms we have to fill out when we go back to a hospital and we have an intake form with a new specialist. I had filled out forms through other specialists. I was the one who was comparing these documents across different groups. The people that had created the documents were looking for the information they needed for their group without necessarily considering what it was like to fill it out. So I had personal experience that the people that were giving these forms didn't have. I was comparing across different units. I could help say, hey, maybe you should make this section bigger, or ask this question slightly differently. So my started with clinical care and moved into research, but it was the exact same experiences I was sharing, and it was the exact same feedback I was sharing. And it is just starting with something that you are confident in, and that you have this experience no one else has. I'll share another quick one. Is one of the major projects I got started in is working with my son's respirologist, actually, because when we transitioned home from the hospital, I shared with her just on a personal conversation how terrified I was. Just that feeling of terror of going home where I had all the same medical equipment, but no emergency button to press like we did when we were in the hospital. My emergency button was now a 911 phone call. And that feeling of terror actually started an entire research project that we're doing a randomized control trial on, because it was like, how do we eliminate that fear? Because the respirologist realized that if you had terrified parents, then care was potentially compromised, because they needed to be able to be confident in the care to take care of their child at home with mini ICU. So we worked on not necessarily doing training or things like that, but how do we build confidence, that feeling of confidence, because the feeling was terror. It wasn't an education gap. It wasn't anything like that. It was addressing that feeling. And I think if you share those ideas, you can start those great conversations and move forward into research in this area.
Wow, that is great. Peter, what is your experience in bringing parents into research? And how do you keep recruiting parents? Because there's a lot of times the researchers come and ask us, how do we recruit parents? How do we keep them engaged in research projects? And I think now more and more researchers want to have collaboration with parents, but how do we find them and keep them interested and engaged in research?
Yeah, it's a great question. I think my first exposure, so I did my PhD in the University of Oxford when I was doing medical school, and at that time is when the James Lund Alliance was being established. I remember being at these conferences, seeing individuals talk about how these co-creation sessions with parents and caregivers, and I was really inspirational seeing that, and really generating information that was a very different perspective from what's currently done in research about very different priorities. The classic examples around arthritis, area that there was a huge amount of research on developing new medications, whereas parents or patients just want to be able to have manageable pain and be able to walk and like take their dog for a walk. And so it's not about no pain, it's just about function and physiotherapy. And so I think those discrepancies and those gaps, and then I think, just training and being in pediatrics, I mean, so many times, so many of our patients, there isn't a right answer, and it's really about working with families to come up with what seems to make sense with everything together for them in that situation at that moment. And I think now taking that, that's so easy to say, but taking that into research is very different, which is meant to be very defined, specific, concrete. And I think part of it's just a journey of learning and then trying to understand how can we think of specific topics that we can address that are feasible. And I think that the James Alliance working with Francine has really been how I really started. And my first conversation with Francine was how do I do this in a lot of ways, because I think and a bit of a difference in general pediatric ward, because most of our patients that we'll see will probably only have one hospitalization ever. They'll be admitted for maybe a chest infection or bronchiolitis or a stomach flu, and they'll never be in hospital ever again. So identifying those parents and families to be a part of studies is very different than someone that has someone with a lifelong condition and they're really engaged regularly. So a lot of the parents that are involved are those that have parents of children that have potentially a chronic condition or a lifelong condition, which makes complete sense. But how do we get a different perspectives? Because we want to be able to, because for that parent that's there for the first ever time, the experience for them is real, and how can we help them? So that was how I met Francine, was just, how do we do that? And I don't think there's a wrong way, but it's just learning together. And I think, or how do we engage parents? I mean, I think that's where the most important part is, having families involved from the outset around understanding, is the question of relevance to families. Because many issue with recruitment may be because it's not felt to be relevant or meaningful for families to be involved. And so that can go down to, and so part of the James Alliance was, in our process, was stepping back and sort of being a bit humbled and being open to focusing on areas that others think are important, not what I think is important. And I think that's where one has to be somewhat open to realize, with the top 10, we're letting that guide us, not saying I have these areas I want to research and we combine them. So I think that from a bigger issue around how we focus on research is kind of recalibrating. And I think, but specifically, usually involving parents, give great ideas, and parents will be very honest with you for feedback around consent form, how to recruit, how to whether it's more a Facebook group than on social media. It depends on the question, depends on the nature. So really, it's just around asking, but coming with hands outstretched and saying, what can I also offer? What can I do to help? And how can you help me?
So when you saw the 10 priorities, were you surprised? Or what was perhaps the most surprising thing when you read that? Or you were like, okay, I kind of expected. What was your reaction?
Yeah, it was kind of like, like this completely makes sense. Like this resonates with what we're doing every day. Also kind of like, this is going to be really hard. But I think that's the point, that the things that are straightforward and simple are the issues that aren't really big issues anymore, because it's simple. And it's, these are complicated questions. And so I think it was a bit of a sigh, like, we have our work ahead of us, but in a way that really resonated. Whenever I spend every 2 weeks or periods of time, 2 weeks on the inpatient unit, and when we're on the unit, these are the issues that come up every day. It's been a communication issue with the family, or someone's gone in and done something, or they've ordered a blood test without asking the parent and they've woken the kid up and poked them, or there's a child with complex medical needs and I'm a new staff and the other staff did it differently. How do we hand over? So all of these are actually the things that come up, and they're not this, does this drug work to fix this condition? And I think they're very human and real and tangible, but they're challenging to be honest, around how do you create research to focus on, particularly the way that our research machines are structured. So but they were spot on.
Wow. Francine, let's talk to you about this, because obviously you bring the parent perspective. This always resonates with you. When you presented that result to the clinicians and the researchers, how did they take that from your perspective?
I'm going to step back a second and just say my reaction to this. And I'm wondering if this connects with other NICU parents out there or just parents whose children are in the hospitals. These are the unanswered research questions. My assumption being outside, just, a casual interaction with healthcare is that, these are our everydays in the hospital. You would think that they were like best practices. You would think that there was research around, what's the best way to manage a child with complex needs in the hospital. So the biggest surprise that I had was that these are unanswered research questions. Mm-hmm. Now I know that it's complicated to answer them, and that's probably why they're unanswered. But it from the parent perspective, we go in often trusting that research is being done to know the best way to care for our children. And it was eye-opening to know that, we can help with this because they haven't been answered yet. And let's raise the importance of it. In terms of presenting to clinicians, I think that the same thing as Peter said, which is you get the head nods, you get the, oh yeah, this makes sense. But having them clearly presented in front of you makes you rethink about the research that you're doing. So when you think about the research question that you're asking, I can see kind of the motions in the clinicians' brains about, how do we tackle that question? How do we ask the question slightly differently? How do we propose this question so that it addresses those things that are important? One project that we're working on within PIRN is to address the number one question, which is how do you support children with medical complexity in their experiences? What is their experiences and how do you support their experience in hospital? And we've started really just at the beginning. So we've started with understanding what the literature is out there. We're doing a review of what the literature is out there. Just because sometimes you need to step back right to the beginning when these questions are posed, because you don't know how they've been tackled before. You don't know what research has been done on them. And you kind of need to look at it from baby steps. And I think that's been a really illuminating project that we've been doing, just to understand, how far back we have to just take this to tackle some of these top 10 unanswered research questions.
Right. Francine, what was the most impactful thing for you in this project?
The most impactful thing I will tell you is someone who has, been around clinicians and stuff for a while in the school context as well, is how open and welcoming the clinicians were to the perspectives of patients and families. There was never an attempt in this process to reconfigure the way they were thinking to say, well, we can't answer that, or we don't do things that way, or research isn't done like that. But really being open to the answers that are coming in to say, all right, how do we rethink about this differently than how we've been doing it in years past?
So one last question. I have two questions. One is, how do you manage the expectation from parents involved in research? Because from my experience, when I first started getting involved in research, I said, okay, you have this research, so when is it going to become practice? So how do we manage that? Because it's difficult for us non-researchers to understand that there is a cycle, there is a process, and between the research finds and implementation, there is a gap.
Maybe I'll tackle this one start and then you could add on it, Peter. So one of the things is be open, honest, and transparent with your patient partners. We need to co-learn together. We need to work together. And the one way that we start that relationship is by taking the time to explain what the research process is, to take time to explain, when I ask you for input, this is how it's going to be used. Taking time when research is being conducted to share back how that research has been used, how that input has been used. Make sure there is expectation management. So at the start of an engagement, you sit down and you have a conversation with your patient partners and say, this is what I expect of you. We probably need to meet this often. I'm going to share with you a little bit about what you need to prepare when we meet. Having those things are vitally important, and sometimes we forget how important they are, and we just want that naive input of the patient. It's the same thing you would have if someone were developing a new iPhone. You just want to know what they think. What do you think of the color? What do you think? But that's not what we're doing here. We're working together to collaborate to do better research. We're not just taking input blindly for a focus group and then going back to our back room to actually analyze that data. It's a collaborative back and forth process, and that takes time and investment, to be honest, and explain what the process is from the beginning.
Okay. Peter, anything to add?
Yeah, it is, and it's a great question, and I mean it's a challenge, especially when things don't go well. I mean, don't get funded. Like the bronchiolitis grant. We're, I don't know what number, trying to resubmit it again to get more funding, and parent partners be like, what do you mean? Like, why don't they support this? Like so it's really hard, particularly with these, because these are truly questions that have been driven by parents and caregivers, and then to get a grant not funded because it's not felt to be important can be really frustrating, because it's in some sense, I think unintentionally, it just ends up feeling, well, is this not really important? Why don't people see this? So I think a lot of it is, like Francine mentioned, just really open, honest up front around explaining, the process around how, the research functions in the sense of, funding, grants, the timelines, that it's sort of a long haul. And that's why a lot of it's, building relationships. And it depends on what perspective and what level someone's involved in. Are they, a real partner throughout the whole thing, or are they kind of at different moments in time? But, particularly as most of our research particularly is no other real funding sources other than, foundations and the government. So it really is limited. So it is not ideal in a way, but I think just be open and honest, and then just find incremental ways to make progress and to do things. And then I think making a real effort to communication and closing the loop, like you alluded to, that it's easy for someone just to contribute and then move on and never have actually gone back to say, thanks for your involvement, this is what happened with that product after. And again, all those things take additional time and thoughtfulness and planning those, and remembering about them, and working with partners like with Francine and others. They're good reminders of the need to do these things, and it's just sort of building in processes to make them happen routinely.
Sure. Okay, one last question, Francine. If parents are listening to us today, parent partners, they want to get involved in this project, do they have an opportunity still, and how do they do it?
We have lots of opportunity to be involved. We're always developing new projects that we're applying for grants and funding. So please, if you have any interest in this, you want to share your experiences either in the NICU or in the hospital, after the NICU, and you want to help answer some of these questions, please reach out to either Peter or myself. The PIRN network actually has a patient engagement group that we're developing that'll help drive these questions forward from a patient and family perspective. That group is growing, so please do reach out, and we'll see what opportunities exist.
That is wonderful. Thank you so much.
And maybe if I can just add one thing to that, and then part of it is, part of our, this work is in many ways sort of step one, and then the next step is really advocating for individuals to take on these questions, to do research on them, and to get funding for them. So a lot of our work has been almost more of an advocacy standpoint of communicating these to funding organizations, to foundations, to hospitals, to say, these are what we've been told are the most important. How can you help address these? And in many ways, doesn't need to be research. It can be a lot of these can be quality improvement. Like how do we better incorporate families' shared decision making is sort of an obvious thing that we should always try to be doing anyways. And so I think, communicating these, sharing these, distributing these to others around to focus on, I think, is what people can do.
Absolutely. And I think you can have another chat about shared decision. This is a big conversation with all of us parents. But today I am so grateful to have both of you here sharing your work, your knowledge and experiences. It's amazing. And I really want to bring you back to continue this discussion about engagement and how this project is progressing. So thank you, Francine. Thank you, Dr. Gill. And I hope I see you soon.
Thank you for having us.
Yes, thank you very much. It's been a pleasure.
And to all of you watching us live today, thank you for joining this preemie chats. And we will be back next week. And just a reminder, if you missed part of today's session, head over to canadianpreemies.org to see this episode and all past editions of the preemie chats. We will find many resources on our website and support options available. And you'll also be reminded that CPBF is a charitable organization and depends on support to continue its important work. Consider how you can support CPBF in its mission to empower families of premature babies in every step of their journey. Together, we can create a brighter future for all preemie babies and their families. And I see you again next Friday, 1 p.m. Eastern Time. Stay well.